Uh, Good morning, everyone. Before we start this session, I would like to ask: is Dr. Kenichi Kamiya is in this room? So I think he will not be here. So in this session, we will have only 5 papers for the free paper valve presentation. The rule is presentation for 8 minutes and question for 2 minutes. I'm Thitipong, and this is Dr. Somchai will be the moderators. So we will begin with the first paper from Hong Kong, Dr. Daniel Chan, to talking about the trans-apical neochord.
Okay. Good morning, Chairman, ladies and gentlemen. It's my pleasure to present our early results of trans-apical open beating heart mitral valve repair. Sorry about that. How can I go for the next slide? How do I go for the next slide? Is this one? Which one to do that?
I think it will be low battery.
All right. Okay. Thank you. Thank you. These are my disclosure. All right. First of all, for the background, leaflet prolapse of the mitral valve, commonly we refer to the Carpentier type 2 lesion, is the most common type of cause of the degenerative mitral regurgitation. So caudal replacement is a well-established surgical technique to correct the prolapse with a very good short-term and long-term results. So the rationale for Neochord device is to replicate the artificial cord placement, but it's in a minimally invasive way. So you can see, like in this animation, it can perform in a beating heart without the support of a cardiopulmonary bypass. And also because of the beating heart, we have a real feedback for the mitral valve anatomy and also how's the Neochord performing. So we can take it out, reposition as many times as we like. This technique has been performed for more than 1,300 cases worldwide. The safety and the effectiveness has been confirmed by multiple trials and series. And this technique first introduced in Hong Kong in the mid-2018, so we like to evaluate the early results. During this period of time, so we will identify those potential patients during our routine workup for those symptomatic MR patients, and then we will offer TEE assessment for them. And then finally, 20 patients give their consent to proceed with the Neochord procedures. And this study was approved by our ethics committees. So for the TEE criteria, we have a standard protocol how to assess the patient. But the key idea is to measure the posterior leaflet length together with the anterior leaflet length over the AP diameter of the annulus. And this comes to an index of a leaflet to annulus index, and the result should be at least greater than 1.2, which means that after correction of the prolapse, you will have enough coarctation length of the mitral valve. Of course, we need a 3D TEE to assess the location of the prolapse. So after assessment, we will come up to 3 types of anatomy. Type A, which means the most favorable anatomy for Neochord. So it means the central prolapse of the posterior leaflet prolapse, the P2. For type B anatomy, multiple segment prolapse of the posterior leaflet, meaning P2 plus P3 or P2 plus P1 prolapse. For type C, which is most challenging for Neochord, so the prolapse involve the commissures, anterior leaflet, bi-leaflet prolapse, or presence of the annular calcification. So this is the typical setup. We don't need a hybrid lab, just an ordinary operating theater with the cardiopulmonary bypass machine standing by. And then we need a cell saver and, of course, a TEE. So usually we need a 4 centimeters thoracotomy, left thoracotomy wound. And the entry site is posterolateral to the true apex, which can be identified by finger and TEE test. So when everything's ready, we will mount the CV4 Gore-Tex sutures on the system, and it can go inside the body. With the help of the TEE and the optic signal, the system can grasp the prolapsing segment, and the Neochord will be applied. So it will come out of the entry site. It will be fixed according to the TEE results. But this is our target. We will overdo the prolapse. which we call them overtension of the prolapse, because by the previous experience, the corrected prolapsing segment, they will come up in a near future, so we need to overdo. After the procedures, only aspirin prescribed, and then we will follow up the patients clinically and by the echocardiogram in this interval. So here are the results. So we have 20 patients, half of them is male. So you can see basically for the patient profile is a quite low risk patient with a mean Euro score of 1.85. And they have a good airway function, of course a dilated left ventricle. And about 60% of them have some associated TR, and majority of them have a posterior leaflet involvement. So you can see the distribution of the type A prolapse in 55 patients, type B anatomy in 25% patient, and then 20% patient is in type C anatomy. The mean number of chordal implant per patient is 3.45, and you can see the list. Majority of the patients have 3 course or 4 course inserted to correct the prolapse. Operative time, mean operative time is about 2 hours. Blood loss is about 500 mL, and there's 100% of successful rate. We don't have any patients convert to sternotomy or open surgery. And there are 6 patients have a concomitant left appendage closure. In the in-hospital results, we don't have any mortality in this series. There's no stroke, no acute renal failure or heart failure in this series. Only 1 patient have more than 2 units of blood transfused. We consider as a severe bleeding. So they compatible with other minimally invasive surgery. They usually extubated in the same day, stay over the ICU with a mean length of stays about 6 days. So for the follow-up results, all the 20 patients reached 6 months clinical follow-up and echocardiogram follow-up. 11 of them reached 1-year echo and clinical follow-up. And during the follow-up period of time, we don't have any added mortality or cardiovascular event. So first, for the symptoms. As early as 1 month, we observed there's a significant improvement of overall symptoms. You can see majority of them stay in Neuro Heart Association class 1 or class 2 symptoms. And during the follow-up, the symptomatic improvement keep going and keep quite stable. So for the echo, when we see all the patients at 6-month echocardiogram, we found there's a significant reduction in the left ventricular size, which we call them a reverse remodeling of the left ventricle. So for the MR grade, as you see that all of the patients have a severe MR before operation, and 100% of them can achieve a less than moderate MR early after operation, and they remain, 90% of the patients remain quite stable over follow-up. We found only 1 patient in the type C anatomy have a recurrence of a moderate MR, and 1 of the patients belong to type B anatomy have a recurrent MR during follow-up echo. So in overall, at the follow-up MR grade, the arterial less than moderate MR survival-free is 80% at 18 months. So ladies and gentlemen, I'd like to conclude this study. Trans-apical off-pump beating heart mitral valve repair with the Neochord is safe and is effective, and is a minimal invasive option for patients having a mitral valve prolapse. Patient can have a clinical improvement as early as 1 month time, and the echocardiogram will remain stable, especially those patients belong to type A and type B anatomy. Of course, just like other type of surgery, we need a longer-term results, and also the comparison studies to our conventional surgical results in order to confirm the benefits of this surgical technique. So thank you for your attention.
Any comment from the floor? Any comment from the floor? I have one question. Do you measure the diameter of the mitral valve annulus before the operation?
Yes, during the recruitment TEE. So most importantly, we're using X-plane. So we pinpoint at the site of the prolapse and measuring the leaflet length and the annulus.
Do you have any case of mitral annulus dilatation?
Some of them they do, but the key is that if some patients we have very long prolapse. So in that case, if the annulus is also dilated, then the equation will still fit. So we have to see how long is the leaflet and how big is the annulus. So overall, if the ratio is greater than 1.2, then we can predict a successful repair with the Neochord system. So it's a kind of a relative. So it doesn't mean that when the annulus dilated, it is not possible. So if we also need to see how long are the leaflets too.
Please, please.
I guess you use your measurements for patient selection, so that if the annulus is too large, then you would not do this procedure.
Yes.
Right? However, in all patients with chronic mitral insufficiency, they all have annular dilatation to some extent. And I don't think there's any question that annuloplasty is important, at least for standard surgical repair, and decreases the incidence of recurrence and further trouble. That's been shown over and over and over again. So do you have any plans to combine this with a percutaneous annuloplasty like the Millipede system and Steve Bowling system? I mean, is that where you're going, is to do both of them this way?
Sure. There are already some case reports reporting that. So if we combine with some sort of an annuloplasty technique, basically we can do more patients. So let's say some patients doesn't fit the equation, the annulus is too big, then there is some case report of a combined procedures of a cardio band, percutaneous annuloplasty with the Neochord. But for the annuloplasty thing is that there is also some series in the past. This I would say is a minority, talking about the not so importance of putting in annuloplastic ring in surgical repair of MR, because we can identify some patients they don't need the annuloplastic ring. So and also there's one case series from the Neochord. They measure the annulus length in the follow-up. With those patients only with the Neochord procedure performed, they found that the annulus actually becomes smaller in the follow-up and become more stable. So the key for this procedure is the patient selection. I will agree that too big, then maybe we need a combination or we need a conventional approach.
Very good.
For type C, did you put any cords on the anterior leaflet or no?
Yes. I have one type C patient with an anterior leaflet prolapse, but he needs a 6 cords because the anterior leaflet, they usually have a higher tension because they close rather harder. And that's why we need more cords and also more technically challenging.
Thank you.
Thank you.
So we move to the second paper from Thailand. Dr. Jesada will talk about very experiment on minimally invasive heart surgery.
Good morning, everyone. Today, I would like to present, share my early experience with the minimally invasive heart surgery in the lower northern part of Thailand. Okay, Budashindala Pisolok Hospital is located in the lower northern area of the Thailand with the capacity of the 1,000 bed hospital. And Pisolok is between Chiang Mai and Bangkok, which far away almost 400 kilometers. The
19, 1,000 doses late follow-up. And we have late mortality, one case, which is the problem with the brain hemorrhage at 1 year after the operation. Most of the case in functional class 1 and 2. We have 2 cases with heart failure hospitalization, which occur actually on 1 year after the operation. And recurrent MR more than grade 2, we have 0. This is a bar chart that functional class, majority 17% class 4 and 47 in functional class 3 that gone to post-operative class 1 around 88% and 11% for class 2. And MR severity, we done at post-operative, majority of the case were in non or trivial MR, and 41% is my MR. This is a 5-year survival around ejection fraction and LV geometry is improved significantly, and also we didn't pull too much, but just to pull. The purpose is that I would like to decrease the tethering force that maybe it can happen later on after when later on in 2 or 3 years later, the left ventricle might dilate. So this might be help to decrease the tethering force.
And you take the PTFE on the posterior annulus?
Yes.
Why not anterior?
Because actually, one is that the posterior is easier, and also because normally in mitral valve replacement with the rheumatic, sometimes that I cannot preserve all of the papillary muscle. So in that case, we use the Gore-Tex to suture and relocate and suture to the posterior annulus.
Dr. Rankin.
I apologize for talking so much, but these are great papers and they're very stimulating. I congratulate you on a good study, and you have shown what Joachim Schaefer's did, that with in this type of pathophysiology, that the ring and string, as he calls it, works quite well. Aren't you, and I have two comments, aren't you upset that in that CTS net trial, with people like my good friend Irv Krohn, who published multiple papers on this, that they didn't train all the 22 centers to do this, to take care of the tenting? Instead, they left everybody to do what they wanted to. It's not really documented what was done. And there's a 30% failure rate over a period of a year or two. And it set our whole specialty of mitral valve repair back, I think, a lot. And because it's a randomized trial and it's in New England Journal, it is enormously influential, gets in the guidelines. And, you know, last year, we did an etiology of mitral valve disease paper from the STS database, and the mortality rate for ischemic MR repaired is 6% in the United States, which is pretty reasonable, I think. For replacement, it's 15%. And that everybody has shown that over the long term. In the Duke database with 500 patients, we showed that on average, repair had a 14% better survival over the long term than replacement. And yet, the design of that study was so poor that they came up with, I mean, you can design any kind of study so that there's no difference between the two treatment groups, right? And they just didn't put enough attention to detail in there. So I commend you for coming up with the right answer. Now, the second comment I'd like to make is kind of a pet thing of mine, but this word functional mitral regurgitation, I think, is a disaster, right? And if you look at who those patients are, you know, when we define them in the STS database, we define ischemic mitral regurgitation as patients who had a myocardial infarction within 21 days of operation, and that worked beautifully. And we define pure annular dilatation as patients who had no other abnormalities of the valve other than just requiring an annuloplasty ring. And those are the two components of this functional MR group, right? It turns out they're completely different populations. So if you look at the ischemic MR patients, they're old, they've got worse ejection fractions, they've got worse comorbidities, and that accounts for the worse survival long term. The pure annular dilatation patients are younger, they are predominantly female, et cetera. So to lump those two, you know, like people are doing now, lump them both together into functional MR, I think is really muddles the whole subject further. So I congratulate you on a really nice study, reproduced Joachim Schaefer's work and Lanna and Schaefer's, and keep up the good work. Maybe do some kind of mortality comparison in your ischemic group or whatever, combine with a few other centers and get more patients so you can do a mortality comparison, because we need to compensate for that bad CTS-NET trial that was done.
Thank you very much.
Because we have some time left, I would like to ask Dr. Arai's comment, because you are already in.
Congratulations for a satisfactory result for this kind of very difficult patient group, and not in only the annuloplasty, but in combination with the subvalvular procedure, you get a real nice result. So, yeah, my comment is, yeah, actually, I started to use the same technique of the posterior annular relocation, but then after more than 10 cases, I changed my strategy. Instead of making a retraction stitch in the direction of the posterior annulus, I changed it in the direction of the anterior annulus. What makes difference is post-operative leaflet opening angles. So if you relocate the posteriorly, the opening angle of the anterior leaflet never changes. But if you relocate in the direction of the anterior annulus, it can dramatically improve the anterior leaflet opening. And we summarize the data of our past patient comparing to the, according to the opening angle of the anterior leaflet. Then we find if the patient has a better opening angle post-operatively, the survival ratio, the outcome of the patient is much better than others. But if I look at your data, because your finding shows some kind of reverse remodeling of the left ventricles, probably if it happens sufficiently, maybe even if you relocate the posterior annulus, the patient's condition may be good. So, but if you deal with more dilated heart, I operate sometimes LVDD 80 millimeter or 70 something. In that kind of patient, this procedure have still some limitation. And so I recommend if you switch to the anterior relocation, it might cause a better result, but technically a little bit difficult. And another point is for the how you decide the size of the annular rings. So I started the undersizing, but if you put the ring undersizing, it deteriorates the posterior tethering. So now I use a just size ring instead of the undersized ring. That is my strategy. But anyway, congratulations for a great result. So we are the people concerning about the subvalvular procedure. Please continue to do it. Thank you.
Thank you very much.
Thank you. So our last presentation for this session will be from Dr. Kim from Korea. She will talk about the long-term outcomes on repeated mitral valve replacement.
Thank you very much, and I'd like to thank the organized ASCVTS meeting for inviting me to speak. My name is Hyun Kim, and I'm from Severance Hospital in South Korea. We are here this morning to talk about outcomes of repeat surgical MBR. Here is a paper looking at Carbomedic's mechanical valves used for reoperation for mitral position can achieve satisfactory long-term result even 22 years after surgery. And another paper reported Carpentier-Edwards bioprosthesis had a low rate of valve-related events at 25 years, especially in patients above 65 years old. You know that improved survival has meant that more patients require repeat MBR during follow-up. However, the long-term clinical outcomes of patients who require reoperation for various prosthetic mitral valve dysfunction is not well understood. So, the objectives of this study was to analyze the early and long-term outcomes of patients who require repeat MBR for prosthetic mitral valve dysfunction, and also according to the age of the patient and repeat mitral surgery. We selected 238 patients underwent repeat MBR from 2005 to 2019 to evaluate the cardiac-related events and deaths. They had prior mitral valve repair or replacement surgery history. Mean follow-up duration was 8.3 years. A demographic and clinical characteristic of the study are shown in this table. Concomitant procedure at the time of prior mitral valve surgery were performed 67% of patients. As you can see, the blue dotted line, there was a trend for increase of repeat MBR. If you can look at the two cases, the first time duration from first mitral valve operation to second case was mean 15 years, and the second duration to third case was mean 9 years. At first reoperation, the indication of repeat MBR was paraprosthetic leak and structural valve degeneration. At second reoperation, paravalvular leak was predominant indication for repeat MBR. Among prior valve replacement group, the indication of repeat MBR for bioprosthetic valve was paraprosthetic leak, structural valve deterioration, or followed by endocarditis. And in the prior mechanical valve group, paraprosthetic leak, structural valve degeneration, endocarditis, and thrombosis were causes of reoperation. And the most common site of paraprosthetic leak was posterior rim. Of the 24 patients who underwent prior mitral repair, such as valvuloplasty or chordoplasty, mitral stenosis was the main indication of repeat mitral surgery. However, of the 21 patients underwent prior ring annuloplasty, Record MR or laser MR was the indication of reoperative MBR. The most common site of regurgitation in prior repair group was also posterior leaflet. These prosthetic valves were used for prior MBR as first or second surgery in our center. In the repeat MBR operation, 105 patients were implanted to mechanical valve and 133 patients were implanted to bioprosthetic valve. There was a difference to mean age and sex proportion, but other preoperative hemodynamics were similar to two groups. Among them, a total 70% of patients underwent concomitant procedure with redo MBR, including aortic valve replacement, TAP, or CABG. Total bypass time and ACC time was like this and was not different between groups. In the repeat surgery, difficult to approach and calcification around the mitral valve induced the downsizing of prosthetic valve. Especially 27 and 29 millimeter prosthetic valves mainly used for repeat surgery in our center. After surgery, post-operatively hemodynamics were stable and reliable. Early and late outcome, cardiac and non-cardiac related events were no difference among them. And there was 6 cardiac-related deaths and 19 non-cardiac deaths cases. There was also not different between groups. Overall survival rate of 10 years was 78% in tissue valve versus 89% in mechanical groups. In this Kaplan-Meier analysis, we observed the difference was not significant between the valve types. Cardiac-related deaths and paravalvular leaks were similar to that. We divided the patient to the age at the repeat MBR, such as less than 40, between 40 and 60, and more than 60 years. This left figure shows you a significant difference between the groups in overall survival, but interestingly, in particular to cardiac-related deaths, there was no difference of survival rate among groups by age. In this study, Cox regression analysis showed that old age above 70 years at repeat MBR and multiple surgeries were risk factor for overall survival after repeat MBR. However, Cox hazard model confirmed that low LV ejection fraction was only associated with cardiac-related deaths after repeat MBR instead of age or number of prior surgeries or something. So in conclusion, our study showed the risk of repeat MBR was low and suggests that age-specific and prosthetic valve-specific prognostic information regarding reoperation in patients undergoing repeat MBR, so it allows physicians to better estimate long-term result. Limitations of our study were retrospective and non-randomized character and small sample size and small event rate and other compounding factors such as heterogenic techniques and medications. That's it. I once again thank you for allowing us to be here.
Dr. Kim, do you find any difference between those who have mitral valve repair and replacement when we do the second operation?
No. We excluded the redo and mitral valve repair case. Only repeat. They had a history of mitral valve repair, but current operation is only replacement case.
Yes, I mean those who have first operation as repair and the second operation as replace.
Yeah.
And compare between this group and another group is first operation is replaced and second operation is replaced.
I didn't analyze the patient, but because our center, I don't know why, but mitral valve repair, and then replacement case was so few. So I didn't analyze the two groups, repair and versus replacement.
Dr. Patterson.
Congratulations. I just want to ask you about your reoperation technique and how you put in mitral valves in your center, whether you use pledges, you put the pledges on the ventricular side. When you reoperate, whether you take the prosthesis with the sewing material and the ring radically out, or how do you approach that? Is that an explanation for the choice of somewhat smaller valves the second time?
You mean our center strategy for reoperation mitral valve?
Yeah, both when you operate the first time and the second time. Say, how do you actually put the valve in, and how do you put your sutures, and what kind of sutures do you use?
Suture technique, you mean? Yeah. We are all about 3 surgeons for mitral valve surgeon. They all select the pledged interrupted suture for redo mitral valve surgery.
Which side do they put the pledges, above or below the annulus?
Pardon?
I mean the pledget inside the ventricle, on the left atrium or on the left ventricular side?
Arterial side.
Atrial side, okay. And
No, ventricular side. Mistake, ventricular side. Yeah.
And when you reoperate, you take everything out?
Yeah, everything. We count the number of all removal for all removal, and then check out and any residual pledget, and then re-pledget suture to it.
And do you have any complication on the annulus, like annulus rupture, bleeding, something like that, after the reoperation?
We are. I check out your comments, but rupture or detachment or annular suture is no patient.
Dr. Rankin.
A few years ago in the Duke database, we did a long-term analysis of mitral procedures, approximately 3,000 cases over 25 years. And of course, using multivariable Cox model analysis, the ones that did best were the repairs, right? And we know that. But if we look at the difference between tissue valves and mechanical valves, the mechanical valves had a statistically significantly increased survival compared to the tissue valves in the mitral position. And it's not that way in the aortic position. I think in the aortic position, both tissue valves and mechanical valves have the same type of outcome profile, but in the mitral position, mechanical valves do better, probably because the closing pressure on the tissue valve is higher in the mitral position because it's systolic pressure, and the valves degenerate faster. So you really showed the same thing, and I think if you had a larger sample size, you probably would have had a statistically significant improvement in long-term survival with mechanical valves versus tissue valves.
Your comment is good, and thank you for your comment, but I think our study sample size was too small, so your opinion is I totally
That's
agree
okay, though.
with
It's
you.
a beginning. It's good, but still, you know that insignificant p-value, which was actually marginally insignificant, would probably become significant if as you get more patients in the future.
Thank you.
Because the mechanical valves, if a patient can't have a repair, I think mechanical valve is the preferred operation in the mitral position.
Thank you, Dr.
you.
Kim. So, I am Dr. Somchai. I would like to thank all audience, speakers, and Professor Rankins, Professor Patterson, and Professor Arai who stay with us until the last minute of this meeting. It has been a very educational session. Thank you very much.